Well, first of all, thank you, Danny, for that very generous introduction. Thank you to Devil, Dr. Atkins, and really the whole Citywide organizing committee for the invitation and for what you have built. It's really quite impressive. As Danny mentioned, my name is Nilesh Mathuria. I'm one of the EPs with the Houston Methodist System. I'm between Methodist West and downtown. And I was asked to talk about VT ablation, specifically managing the storm is no longer that last ditch. So what does that even mean? When it comes to, at least us EPs and many cardiologists, how do we even define storm? So we're all familiar with patients that may have had a ventricular arrhythmia, perhaps an ICD shock, perhaps it's a one-time event. But certainly there are some patients where it comes in clusters. Specifically, this storm definition that's been sort of now applied to our EP literature is patients that have 3 or more sustained VT episodes, VT or VF episodes, typically within a 24-hour period. As you can imagine, many of these patients already have existing ICD, so oftentimes this may be 3 or more shocks, but it doesn't necessarily have to be shocks, if you will. And in this ICD patient population, as we like to say in medicine, this is not uncommon. Various registry studies have shown anywhere from 10 to 20% of ICD patients do present with VT storm. So again, 3 or more shocks within a 24-hour period. And as you can imagine, these are more likely in so-called secondary prevention ICD patients, patients that have already had an ICD due to history of sustained VT or VF. And so why does this even matter? I mean, you'd say, well, okay, you just give them amiodarone or et cetera, they get better, what's the big deal? But the prognosis for these specific group of patients is extremely different compared to isolated ICD shocks or isolated VT episodes, interestingly. So as you can imagine, of course, these folks will have, increased heart failure hospitalizations or increased heart failure decompensations, but more importantly, these patients die. So this is actually a really powerful forest plot that was published here from a group in Canada that looked at the RAFT trial, which is an older trial looking at ICDs versus, BIV ICDs versus ICDs in patients in left bundle branch plot. But they had access to the ICD data and looked at clusters of VT. So not just specifically VT storm, meaning VT 3 VT episodes in 24 hours, but they looked at any patient that had 2 or more episodes of VT over a 90-day period. And they were able to categorize those as were they within 24 hours, 3 days, 7 days, 30 days, 90 days. But as you can see here, hopefully it projects well, the point is the more VT episodes, the more ICD shocks or ICD therapies you had over a cluster of a period, that incrementally increased your chance of death, mortality. So this is not, the endpoint here was not recurrent VT, the endpoint here was not recurrent hospitalizations. And as you see here, it's a very powerful forest plot with hazard ratios of 3 to 5 times mortality risk in these patients that had more than 3 to plus episodes. So it's not just the VT storm, quote unquote, within 24 hours. I would even consider more as a cluster of VT episodes, that these are patients that are specifically much, much higher risk, if you will. So where does catheter ablation come into all of this? So traditionally, this has always been considered, quote unquote, a last resort or this last ditch effort after various drug therapies fail, and really kind of a last resort, if you will. But what I hopefully will show you here, some contemporary evidence would suggest that catheter ablation may actually be superior to currently over escalating drug therapy. So this is a paper that at least I had an opportunity to be involved in. This is one of the largest VT ablation registries that we have with, as you can see from the number of authors, a multi-center experience of like 20 plus VT ablation high volume centers, mostly around the country and a few internationally. And we are able to collate our cases. And what's the nice advantage of this cohort is not only do we have demographic data and outcome data, but we actually have procedural data as far as the VT ablation, how many VTs were induced, how fast were the VTs, et cetera, et cetera. But anyway, this was a paper where we specifically looked at patients with VT storm, the same high-risk patient population, and actually looked at their VT ablation outcomes. So again, every single patient underwent a VT ablation. But again, I don't know how well this projects, but you see the top line, the green line, those are patients that had a successful VT ablation where at the end we could not induce any VT. Conversely, the red line at the bottom were patients that underwent VT ablation, however, were still unsuccessful. We could still induce what we felt like were the clinical VTs or other VTs. The point is, at least in this retrospective sub-study, if you will, so again, a lot of, take it with a grain of salt, from a statistical perspective, but still a very large experience. Patients that had a successful VT ablation had a significantly higher 1-year survival rate. So we're not talking VT recurrence, we're not talking heart failure or hospitalizations, we're talking about the ultimate endpoint, death. And so these patients lived longer with successful VT ablation. So again, at least it provided a signal that perhaps ablation may do something more than just simply palliation, if you will. This is the Vanish trial, which is, at least in the EP world, well-studied or noted study in New England Journal a few years ago, a randomized controlled trial looking at patients with prior MI and recurrent VT and randomized them to either VT ablation or quote-unquote escalation of medical therapy if they were already on an antiarrhythmic drug therapy, either going to a higher dose amiodarone or switching to two antiarrhythmic drugs. This was a sub-study of that Vanish trial where patients were looked at, only the patients that had quote-unquote VT storm. Again, this high-risk patient population with multiple VT episodes over a 24-hour period. And long story short, patients, basically, essentially the ones that were already on amiodarone, which are oftentimes the patients that we see, did much better with ablation rather than escalating drug therapy. So the recurring theme we keep seeing, at least in some of these sub-studies and even the prior retrospective sub-studies, is that ablation seems to be winning out. And again, these endpoints are mortality, not recurrent VT, so the ultimate endpoint. And more importantly, winning out especially over adding more and more drug therapy, because over time, the antiarrhythmic drug therapy itself has its own negative side effects, if you will. So you may say, well, okay, that's great, I hear you, but look, my patient has an EF of 25, they've got CKD, they got COPD, they got diabetes, they got carotid disease, they got coronary disease. I'm not sure if they can get through something like this. Is this really worth it, if you will? So this is actually a nice study that was done, actually just published last year out of France, where they looked at 4 high-volume centers, 606 patients with VT storm. So again, not just VT, VT storm as we've defined it. And they looked at not only their outcomes between if those that underwent ablation versus those that didn't undergo ablation, but they also tried to see if how they did based on their quote-unquote risk profile. There are various risk scores that are in the EP literature similar to STS scores, the so-called pain ESD score or IVT score. Essentially, the point is that these are predictive scores to kind of predict which patients may have higher risk of hemodynamic collapse during one of these higher risk procedures. And the bottom line is, in this forest plot, again, looking at all the patients that underwent ablation versus those that did not, regardless of your quote-unquote score risk, even if you're high risk versus low risk, the bottom line was catheter ablation was superior and actually improved mortality or reduced death, if you will, compared to escalating medical therapy. So again, another signal, again, retrospective, et cetera, but another signal that a VT ablation, if successful, can actually move the needle with regard to mortality. So to that, I would say consider all patients. I'm not saying every patient, but at least consider all patients. Now, again, this is where being at a high volume center with multidisciplinary services is really critical. But still, at least the point is even your quote-unquote high-risk patient may benefit from an intervention like this. And then you may say, well, when? We all have patients, they come into the hospital, maybe you give them amiodarone, lidocaine, et cetera, and over the next few days, things kind of settle down, and you say, all right, let's just go home, and then we say, all right, that's that, if you will. But there have been some recent studies, actually just in the last couple months, suggesting that perhaps early ablation, even in this patient population, may make a difference, if you will. On the left here is a slide from a group in Germany, looking again patients with VT storm, with a propensity match cohort. Again, a lot of limitations with this, but long story short, patients that had VT ablation that performed within 10 days of their presentation was associated with, again, reduced mortality. And on the right, this is just recently published, this is from the UPenn group, where they try to create another sort of risk profile in, again, VT storm patients. But again, long story short, in their multivariate analysis, one of the highest predictors of improved mortality over time was early ablation within 7 days of presentation. Now, there can be a lot of reasons for this. Obviously, as EPs, we may cherry pick the best patients for this, maybe the same monomorphic VT as opposed to multiple VTs, et cetera. Also, I think just from a practical perspective, I think I see patients all the time that are then on chronic amiodarone and they're, quote, doing fine, but then you see recurrent hospitalizations or issues with side effects over time or recurrent slower VTs, which can then cause decompensation for these patients. So again, another signal that perhaps not just ablation, but early ablation in this sick patient population can actually make a difference with regard to not just recurrent VT, but again, mortality, if you will. So again, sooner the better. So with that, I'm going to conclude. So VT storm associated, again, with higher mortality. Ablation, even in higher risk patients, is associated with improved mortality with contemporary approaches. And I think, again, earlier timing of ablation may improve long-term outcomes. Thank you again for the time.